Yeah, welcome back. So we have case number 24 for you, and Andreas is ready to give the case history. Andreas, please.
During her pregnancy in 2009, an atrial septal defect was diagnosed and severe dilatation of the right ventricle was found. Due to the pregnancy, ASD closure was referred. In May 2013, the ASD was re-evaluated. Currently, the patient has no clinical symptoms and her medical record is uneventful. ECG showed no pathological findings. In TTE, normal LV function was found. The RV is currently only mildly dilated and mild tricuspid regurgitation was seen. In TEE, no intracardiac thrombi formation was visible. TEE showed a secundum atrial septal defect with atrial septal aneurysm and left to right shunt. The ASD measured 11 millimeters and a positive bubble study was seen with Valsalva maneuver.
Okay, thank you very much. So with me is, as I said, Stefan Bertog, and we have Simon Lahm doing the echo.
That was quite a long pregnancy, wasn't it, Horst?
Was it?
Yeah, 4 years.
Well, Germans do it always very well. Is it 4 years? Come on.
Yeah, 2009. Okay.
I have to look at this in more detail when we are offline. So Simon is ready to give you the images from the TEE, please.
So this is a TEE image at the 35 degree, and you can see that at this short axis there is a septal defect at the septum, and with color Doppler you can see the flow across the defect. And I've made some measurement, and the defect is measured about 12 millimeter on this short axis.
Okay. What's about long axis?
Yeah. And this is the long axis view, and you can see the color flow Doppler across. About 14 millimeter.
14.
14.
Okay. So again, say short axis was
11. Was 12.
11.
11.
And long axis 14.
Simon?
Yes.
Can you just show us a 4-chamber view? Because
okay.
Just need to get an idea of the right ventricular
right.
size. So Mario, what do you think? 14 millimeter defect and biggish right ventricle.
Well, I think this is a medium-sized, small to medium-sized defect that is worthwhile closing. There is some ventricular volume overload. I don't think that transesophageal is the best way to assess the right ventricular volume overload. But when you bring the patient to the cath lab, you already decided that you want to close the defect, actually.
My question really was, if the right ventricle is so dilated for a medium-sized defect, whether there is possibility of anomalous pulmonary venous drainage.
That's a possibility, but should be ruled out by echo as well. But sometimes, particularly in adults, small to moderate-sized defects are enough to cause a significant right ventricular volume overload.
Yeah. Okay. Zahid, what do you think?
I agree. I think we need to rule out. Plus, how do we see the rim towards the pulmonary vein here? We are not seeing that. So I suggest if he could rotate the transducer without changing the angles clockwise, then the rim towards the pulmonary vein will come into view.
Okay. So can you show us the right pulmonary vein drainage? Yeah.
I think that's a good point, Shaq, though in the adult where it may not be as easy by transthoracic to see pulmonary venous drainage, in the kids we don't worry about it, we can usually see it, but if you have RV volume overload out of proportion to the size ASD you see, then perhaps ancillary imaging if you want to do TEE or CT MRI.
Yep. Okay.
Okay, so quick poll, what device size? Okay, so again, this patient is pre-scheduled to some degree to a certain device.
Okay.
Would you prefer any device, or can we
So
use any?
before that, I'm going to ask Stefan a question. I'm not going to ask you because I know the answer. Stefan, heparin
probably
and
know the answer.
ACT.
ACT, yes. I would say it's about 280.
Oh, right, it's gone higher.
Yes, yes.
How much heparin was that with?
10,000.
Okay, thank you. All right, let's have a quick view of the type of devices, or type of device and the size. Abdul, at the back.
I think you could use anything you want for this.
Anything. Size-wise? 40 millimeter then. You
No, I was
said
talking
anything.
about make.
You said anything. So what size device?
Caught me out, I wasn't paying attention.
Yes, I know. Gareth.
Either a 30 millimeter GSO or a 14 or 16 Amplatzer type device.
So 30 millimeter GSO or?
Yep. Or a 14 or 16 Amplatzer type. Or
Okay, Zaid, what would you use?
I would measure the defect one more time in short axis view before I decide.
Measure it again. He measured it.
In short axis view one more time, if it's
all right.
possible, please.
Okay,
What do you
Simon,
want to
short
do?
axis view again.
I want to see the rim. You see the posterior rim is very, very thin. So if you were to
Okay.
balloon size this, that rim would move away, and so would the device if you're putting a self-centering
Okay.
device there.
What measurement do you want him to make it?
I want to include that thin rim where I
Turn the
would not
probe
want him
to
to
the
measure.
right.
That should be part of the
Simon.
ASD.
Okay.
Turn the probe a little bit to
Okay.
the right so we can see better the posterior septum.
Okay, can you show us that short axis view again for Zaid?
Well, actually, there is no really deficient aortic rim in this particular case.
Yeah.
It's
Yeah.
more represented than usually happens in real life.
Yeah.
Okay. Raphael, what type and what size device?
Size after sizing.
Size after sizing.
But I wanted to stress the fact that actually in all the cases that we did until now, we weren't shown all 4 pulmonary veins. I think this is essential that we request to see all 4 pulmonary
Yep.
veins draining before we proceed for this kind of procedure,
Yep.
not only in disproportionate RV enlargement.
Yep. Okay, good point.
14 device.
14.
just the other thing is just there's a catheter across here already, so you've got an almost partial balloon size already because you've pushed part of the septum away with the catheter, so it's probably a more true size than without a catheter across.
Yep. Okay. Any other suggestions?
Turn it
I
more
think
to
a
the right.
14 will
Turn the probe
work.
to the right.
Horst,
See if
have
you
you
can
already
see.
balloon sized it?
Sure, but I don't want to tell you the measurements until you have decided which
Yeah.
device to use.
Okay. Quick show of hands, those who would not balloon size this defect. And those who would? Okay. Those who would not balloon size once more, just put your hands up again. All right. So what size and type of device would you use for this 14 millimeter defect?
I'll use 14 millimeter AGA device or Occlutech.
14 AGA or Occlutech?
16.
16 back there. I can't see. You had your hand up. 14 or 16. Madullah.
18 Occluded.
18 Occlutech. We're going up. 18. Any other? Yes, Michelle?
15 Occlutech.
15 Occlutech.
So it's interesting. We can get all numbers you want, actually.
Yeah, you can take your pick from anywhere between 14 and 18.
And if
Okay.
you take the average, it will be 16.
16 is the average.
Okay, let's show the balloon sizing now. Jürgen?
23. So your measurements are inaccurate.
Which ones?
I don't know. But,
So which
okay, so
device
now
size should we
those
use now?
quick show of hands, those who are going to balloon size. Joe, you've got a measurement there now, balloon sizing.
Yeah, but this is not stop flow. This is waste.
Waste,
and,
yeah.
I think what as Zaid mentioned, it's a flimsy margin at the back. So I really wouldn't oversize it like this. I think it's a little bit overstretched.
Okay, there were some other hands.
let you know the pressure in the balloon was 12. The pressure in the balloon was 12 millimeters of mercury.
Right.
Chair.
Yes?
Yes.
Yeah,
That would
go
be
ahead.
great if you can show us the echo, I mean, together with balloon dilation, the balloon inflation, because I think it's overstretching.
Yeah. So echo during balloon inflation, but not stretching the defect like that. Go ahead.
The stop flow, the diameter is also very important
Yep.
during balloon size.
Okay, so we don't like that balloon, Horst or Stefan. We wanted a stop flow technique.
Okay, so we have to measure again.
Well, just a comment about the stop flow, overstretching, etc. It depends on the pressure of the balloons, but it also, or more importantly, it depends on the consistency of the rim.
Yeah.
If you are very, very floppy rim, even very small pressure in the balloon will stretch a lot.
But the interesting thing here is that we were talking about floppy rims, Zaid was anyway. Here, what you do know, and it's a perverse way of thinking, the device does not need to be more than 23 millimeters. Yeah? Because that's a stretch, balloon stretch. And
it's actually 23.6.
23, okay, so the device has to be less than 23.6.
Can I just ask about the balloon pressure? It's something I'm not familiar with. And what cutoff do you use? How do you use that nominal pressure in the balloon to tell you whether it's adequate or not? I'm not sure of the concept.
So we measure the pressure inside of the balloon. When you look at my hands here, I'm just connecting the KIST system to the lumen of the balloon. So that means we can all the time measure the pressure inside of the balloon. So currently, can we have 40 scale on the pressure, please? So currently the pressure inside of the balloon is 3 or 4. So now we will start to fill the balloon with contrast. You can advance a little bit more, fluoro, please.
And what is the normal pressure you take the balloon up to?
Well, not more than 15, 20 usually.
Okay, but that is stretching the defect.
Yeah, I mean, but it's very low. It's almost the pressure in the atrium, right?
I think that's the question. Where do you get that pressure from? What's your physiology behind saying that 15 is the right pressure to go to?
Well, it's the same pressure as you have in the LA. So I'm basically filling it without pressure. That is the message here. Actually, when you want to tear a septum, which is a normal septum, they need a pressure of about 500 millimeters of mercury. If it is a very flimsy septum, you may be able to tear it with a pressure as low as 50 to 100 millimeters of mercury.
So, Horst, can you work out from your pressure concept then what pressure you need for a stop flow technique?
I don't know because I don't use the stop flow technique. So, but
well,
we
can
will
you
test
do it
it
now?
Yeah, we'll do it now. So
you might learn something.
Yeah, of course. I'm always learning something. Okay, don't pull it through. So, okay.
We see the echo.
Now we need to see the echo, and Simon, please check for any residual flow around the balloon. We need to see this from all different views.
Probably on 78-degree view.
That's perfect.
I think you should try and measure it in the middle of the balloon.
Yeah.
Actually, you see the waist in the proximal part of the balloon. And I remember many years ago when we've been using the spheric balloon to size the defect, sometimes it was really difficult to assess the so-called stretch diameter when pulling the balloon back from the left atrium to right atrium. Sometimes it can be used to do the opposite, or inflate the balloon in the IVC and slowly advance from right atrium to left atrium and see where you stop in the flow.
Horst, now what pressure is that balloon at?
The pressure in the balloon is now 11.
Okay, it's still stretching the defect. Because there's not going to be any flow yet, but if you
you could also say there is no pressure at all in the balloon because, again, this is without pressure. So we have 22 millimeters now.
We need to measure by echo.
Yeah.
Stop flow diameter will be echo, never a fluoro diameter.
I also think the angulation is not quite right there. I think there's some overlay on that balloon, so it's still folded, and you're not getting the minimum waist.
Okay, so Simon, can you try to measure the diameter of the balloon on echo? Seems to be not so easy to get a good view here.
Yeah.
Advance the echo probe a little bit.
Well,
Yeah.
My personal attitude when doing balloon sizing is to look at the echo to get an information on the stop flow.
This is not the maximum diameter.
However, the measurements I prefer are angiographical measurements.
Right.
I mean, most often by echo you are off axis, and it's not accurate in my opinion.
I think, Simon, you'll have to just rotate through the angles in order to get the whole length of the balloon.
Yeah.
Only then can you get the maximum diameter.
So probably about 60 degrees should be the best.
Yeah. 78.
78? Okay.
It's like your pressure in the balloon, 12.
You got a great waist right there. In this picture, there is a very good waist. That's where you need to measure.
It's cutting across, isn't it?
Yeah. It's a great waist right there.
Now there is.
If you freeze it, you can measure where the constriction is from the aortic side. Yeah.
But I think Mario is absolutely right. You can see how operator dependent this is, and it's certainly much more reliable to measure the angiographic picture then.
You have to go to the right side where you see the dimple.
Yeah.
Okay.
Oh, I can't see the measurements. Okay, yeah.
So what's
what is
that?
18.
18.
So we're slowly getting down now
Yeah,
from
yeah.
24 to 22 to 18. And
No, but we measure 22 with angiographically, and that is just because if you don't catch the right plane with echo, then obviously it's wrong measurement.
Okay.
Did you do calibration with the markers as well?
No, this is isocentric calibration, which is more reliable than the markers, because with markers you can have a foreshortening, whereas with isocentric it's reliable.
Yeah.
You would like to see the shaft when you do the balloon measurement, otherwise you know that you are off axis.
No, but this is isocentered, so there's an inbuilt correction.
Yeah, but if you measure the markers, you'll get some
Oh, I
idea
see, yeah.
about how accurate that
So
might
he's-
be.
No.
got to
The markers can never be correct
Yeah.
unless they are really perpendicular to the X-ray beam. And
Yeah.
that's
He's
something
got-
you don't know.
He's got to find the markers that are perpendicular. That's the
Yeah,
problem.
but Joe's observation is interesting. I agree with that. When you don't have an isocentric automatic calibration and you use the calipers on the balloon, at least is our practice, it's nice to make the calibration, measure the size of the balloon you want, and then remeasure the distance between the markers. That should be the same number as the calibration.
Well, it's
Because
only
if
the
the
same.
wires are-
It's only the same number if the markers, the catheter is perpendicular to the X-ray beam, and that's
yes,
something
absolutely.
you don't know.
You have to choose a projection where you're profiling the calibers adequately, not doing a foreshortening. Yes.
So
If the
balloon
markers are off
sizing on
axis, if the markers
echo.
are off axis, then the balloon is off axis.
Yeah.
Yeah. So Joe, balloon sizing on TOE, we've got a measurement of around 18. What device now?
Yeah, I would not go beyond 18. I think it's 18 is probably generous here.
Right?
Yeah.
Can you
I
remeasure
agree
this?
I agree with Joe said. I mean, 18 I think is very generous.
Alison, what do you want to
Yeah.
remeasure?
I think you have a different fluoro balloon now compared to the previous one. So can you measure this to correlate with the echo? But I still think I would go back to the original 2D sizing.
Yeah.
Well, you see these angiography moving pictures. You have different size of the balloon. Yeah. Can you replay this, Horst?
Yeah, I'm
Do you
just
mind?
doing this. Yeah.
This one, yes. You see?
Yeah.
It depends what frame
It's
you choose to
superimposed,
make
isn't
the
it?
measurement.
It's the
It's
dilated
going to
bit is
be
superimposed
at
on the narrow
least
bit.
3 millimeter, 4 millimeter difference between the frames.
Yeah. Which is why it's easier not to balloon size.
And rely on echo, where we ended up with a 14 millimeter device, right?
Well, no, I think, I can't remember who said it, but if it's a 14 millimeter defect and there's floppy rims, you add 2 to 4 millimeters, and there therefore you finish up with either 16 or 18 device.
I think we ended up with 18 the maximum, but the majority was for 14 when we saw the
Yeah,
echo.
well, we
around.
might change our minds in a minute. Gareth?
Yeah.
Really quickly, the echo pictures that you're showing in the moment are showing a nice waist, and intermittently you're seeing the wire going through the center of the balloon, which means you're nicely in the middle of the balloon. So that's actually probably a really nice echo picture to measure there. You're seeing a nice waist, and you're in the center of the balloon.
Yeah.
But look how variable that diameter is. I mean, during this run here, you see always the wires in the center, and you see how variable these measurements is. The same as with angiography. There's no question about that.
Yeah. Yeah, go ahead.
In the isocentric calibration, table object distance
never changed. So it's a more accurate calibration than the marker calibration. But it's also very important to take measurements in different
Wo sind die Occluder?
fluoroscopic
Wo sind die
views.
Occluder?
I mean, for example, LAO or anteroposterior
Wir brauchen eher einen
posterior
22er,
views.
das es gibt, oder einen
It's
21er.
just a matter of working out the length of the balloon, isn't it? And it's not always the same angulation.
What size balloon was it? Because that makes a difference as well. If you use too big a balloon, then it's more difficult to get stop flow as opposed to using a big balloon.
So, Stefan, what balloon was it that you were using, and what diameter?
It's a 40 millimeter not NMT anymore. It's a new made balloon.
40.
40, yeah.
Okay. I would have used a 24 sizing balloon. Yeah.
Well, why? I mean, if you need higher pressure to fill a smaller balloon up to
I
the
don't know.
nominal
I don't normally use the pressure, so I wouldn't have used
Yeah.
a higher pressure within the balloon. But Dietmar.
So I believe in the sizing of the balloon sizing because we have talked about the discrepancy between the color ASD and the huge right atrium diameter. So I think by exercising, the patient will have a dimension like 20 and during rest maybe 14. So I think this discrepancy can be dependent on the left ventricular end diastolic pressure, that you have maybe in high end diastolic pressure, or even that you have a variable let me say ASD size depending on rest or exercising. So I would use a 20 or 22.
20 or 22. Abdul.
I mean, we're reaching a size looking at the echo normally and then just using the balloon size to modulate a little bit up or a little bit down depending on the floppiness of the septum. But if you're using an Occlutech device, the range of sizes is so broad that you seldom need to use the balloon sizing because it's not going to take you to a different device.
The point I was trying to make with that measurement so far is that the floppy septum apart, you've got a fairly rigid 20 or whatever 18 millimeter measurement, and that is the firmest bit of the septum now. So it can't be anything more than that. That was the point I was trying to make earlier on.
But even
Abe?
If you measure the stop flow technique, if you come from the left, pulling back, you'll get a larger size comparing with the size you'll get if you go antegradely from right to left.
Okay. Yeah.
I just have a comment and maybe you can answer it. I'm just wondering, why do we have 1 millimeter increment size devices if sizing wasn't important for ASDs, and why we have only 4 different sizes for PFOs? So there has to be a reason behind this madness. So that means accuracy in measurement of ASD for a self-centering device is of crucial importance.
It's essential, yes. Okay, Horst, what are you thinking now, having done the sizing?
We decided to use an Occlutech device.
And diameter, size?
Well, at least 21.
Oh, 21.
Yeah. Definitely 21. I would not go for smaller than that, and maybe that should be okay. But I would not use a smaller one. I completely believe in balloon sizing.
Yeah. Okay, the thing that's interesting for the audience, I guess, is the measurement of the balloon, sizing balloon, the pressure measurement inside it. I don't think, is there anybody else who uses, who measures pressures in the sizing balloon? Nobody.
May I ask you a question to the people in the audience that would not do a balloon sizing? In this particular case, Horst decided to use a 21 millimeter balloon device. Yes. In your opinion, somebody said, I will use 14, I will use 15, 16. Did you change your mind based upon this observation of sizes, or you're still going ahead and use 14 or 16 millimeter balloon device?
Okay, so those of you originally who had your hands up for not balloon sizing, can you just put your hands up again? Yep. Right, Michelle, I can't remember, you said 14 or 16.
Yeah, I said Occlutech 15, but
15.
I think with that thin or flimsy posterior rim, I will go with 18, not more.
But
But is that not another advantage of balloon sizing? It's not just the size, it actually tells you a bit about the septum and might modulate, a bit like Abdul says, modulate what size you pick, because you know this is a very floppy septum, it moves very
Well,
easily.
I think you're absolutely right. I mean, when you have thick margins, the size, the balloon sizes will not be different from the static measurements on the echo. What it makes the difference in the consistency of the rims. That's the key point for sizing.
But if you've got a floppy septum, and it really depends on your TOE images, I tend to go for, there's a hinge point where the floppy septum moves, and it's that hinge point which gives you an indication of the stiffness of the septum.
That will more or less correspond with the sizing.
Yeah.
So let me explain briefly the device. This is again the Occlutech device, which has no hub on the left atrial side. There is a little ball on the right atrial side. Otherwise, it looks comparable to the other nitinol devices. The delivery cable has a handle like here, where I can, okay, so now when I just pull on the black handle, you will see that little grabbers come out of the delivery cable. And these grabbers will grab.
Zoom in a bit more on that, onto the grabbers. No, zoom in.
Zoom in. Größer machen.
Make it bigger. Make it bigger.
Ranzoomen. More. More. Okay, so these little grabbers will grab the ball. Now I release the black thing, and now it's attached. Okay.
You can see how flexible it is once it's attached.
Exactly. This is the advantage of this mechanism, that it's very flexible now, so it's not a perpendicular connection to the delivery cable. So in order to prevent dislodgement of the device, I have to screw this red thing towards the, what is this purple thing? And this prevents me from losing the device inside of the sheath. Oh, I forgot something. We forgot the loading tool.
Yes.
So we have to, yeah, good. So
well, that was a good test anyway.
Yeah. So I will release the device again. I open the red screw. I pull on the black thing, and it is released. Now I add the loading tool. Actually, let me also add, in this case, also the Y connector, so we can avoid any back bleeding if some problems arise. So I'm advancing the loading delivery cable through the loading tool. I'm again pulling on the black thing, and I will reattach the device to the ball. And the best way is to do it this way and not like this way, so it's better to do it in a flat fashion. Okay, now it's attached, and now we'll screw the red thing again. Good. So now we can load this as all the other comparable devices. Someone yesterday told me it's better to flush instead of aspirate. No, aspirate instead of flush. But I can do both here. Okay, so what is important now is to really pull
What's the difference between aspirating and flushing? What difference does it make?
I don't know. Someone
it's
told
like your measurement inside the balloon.
Now I have 3 different sounds on my microphone here, on my loudspeaker. So, okay, so what is important with this device is to really pull it back into the loading tool. So although you could also introduce it into the sheath when it's pointing out like this, this may actually be difficult to bring it out of the sheath at the end. So it's better to pull it back completely into the loading tool. And now we are ready to connect the loading tool with the sheath. And now Stefan will advance the device up to the tip. And it's important, as discussed yesterday during one of the other cases, there's no distal hub. So the radiopacity is not as with some other devices where you have a hub as a marker.
Could I ask something? Is there anybody else who de-airs the sheath on the right side, doesn't take the dilator out on the right side, and then advances the sheath over the wire into the left atrium to avoid air entrainment?
Okay, Mario.
No, I usually don't. I try to make it as simple as possible. I advance the sheath in the left atrium and take the wire out and the dilator very, very slowly in order to allow the blood to fill the sheath. When you have a good back bleeding, I insert the device flushing.
Ingo?
Now he's pulling back the sheath, exposing the left atrial disc.
Yeah. Ingo, very quickly, de-airing.
Inside the left atrium.
Anybody does it on the right atrial side?
More.
Yeah, Raphael, Michel, 2. Yeah, just the 2.
Okay, now you see the left atrial disc is almost exposed. A little bit more. A little bit more. Okay. So now the best way to deploy these devices is to rotate the sheath towards the, let's say, right upper pulmonary vein. So rotate it clockwise, the whole system.
Simon, show us the short axis view.
No, long axis, please.
Long axis?
Oh, you do it on long axis,
yeah.
do you?
Yeah.
Okay.
So rotate more. We want to really have it on the right side of the heart.
So, Horst, if there's absent aortic rim, do you still deploy on long axis view of the on echo?
Yeah.
Okay.
Okay, so it's still not in a good position, so you may pull it a little bit, and deploy a little bit more of the device. It's in a bad angle to the septum, you see that? So rotate again. Maybe you rotate back first, counterclockwise. Counterclockwise. More.
I think the left disc is too big.
Okay, now start again and rotate it clockwise. Yeah, okay, now it's looking a little bit better.
Come back with the whole device.
But it's, again, when you look in echo, it's in a bad position compared to the, counterclockwise again.
Would it help if you retrieve part of the disc before you rotate it?
Yeah, that could be an option, yeah. Try that. Partially recapture the device, pull the device back into the sheath. Okay. A little bit more. A bit more, okay. Now rotate again clockwise. You should know that Stefan just joined our group a few weeks or months ago, so he's still in his training phase.
That's right, that's right.
Yeah, he's doing very well.
Yeah.
Does anybody else find the Occlutech device a little bit more difficult to make a ball with, sort of partially retrieve? The implants maybe is easier to partially get into a ball shape if you're trying to do these manipulations. I find the Occlutech pops out a bit more.
Deploy it a little bit more.
Hadn't noticed that in particular. Anybody?
More.
Raphael?
No, I just wanted to say that I usually use the Hausdorff sheet and I
it's prolapsing.
Yeah.
So rotate back.
Go ahead.
Rotate counterclockwise, advance.
I prefer left upper pulmonary vein technique in this case.
Okay.
Well, there are several tricks to overcome this problem, but I have a question just related to the characteristics of the attachment mechanism. It was said that the advantage is that the device can move.
Flexibility.
Yeah, but the flexibility is on when you deploy the entire device. Otherwise, this advantage is none.
Yeah. The flexibility only applies once you've deployed the right atrial disc and there's less tension. But obviously here there isn't.
Yeah, but
yeah.
When you already deployed the right disc and the left disc on the right is okay, the right disc is okay, well, you don't need any lack of flexibility.
Yeah. Okay, so
now it seems
Horst
like
Stefan?
Not in a bad position here. You see the flexibility between the delivery cable and the
yeah, what Mario was saying, Horst, was flexibility works when you don't need it and doesn't when you need it.
It works only at the very end.
Yeah.
I was wondering if you could measure the waste of the device now by fluoro and by echo.
Yeah. Yes, that would be interesting, wouldn't it? Okay. See how much compression there is.
Yeah.
We need a different plane.
It's
here.
probably more accurate on fluoro now because on echo it depends on where you are on the waist.
So we have to go for a different plane now.
Well, I think this is a good point, where you're not sure about the size of the device. If the device is sitting nicely and there is no bulbs appearance of the two discs, it means that the central waist is the right size.
Yep.
Otherwise, you have not a flat appearance of the device. Is that an indirect sign of the good choice of the size dimensions, right?
But also, if you measure the waist, that gives you, because this is a 21 millimeter device, so let's be interested to see what the waist is.
Yeah, I have a question about that.
So what's the waist?
17.
There you are. So 18 would have worked.
Yeah.
Yeah, probably.
Yeah. So say there was a question.
Yes.
Taiji.
Yes. When I use for the light upper pulmonary approach, when do you say manipulate for the changing the Cs? Just while completely open the left atrial disc, or something like say tulip bubble.
Horst,
can
if I
you repeat
understood
that?
it correctly, I'll rephrase Taiji's question. Why do you deploy the left atrial disc in the left atrium and then rotate towards the right pulmonary vein? Why not put your sheath in the right pulmonary vein and deliver the device and pull it back there?
Because balloon sizing is easier and better to measure when you have the wire in the left upper pulmonary vein. But otherwise, for deployment of the device, it's actually a good suggestion to start from the right. But then I would have to exchange my wire position. That's the only reason.
Okay. Was that your question, Taiji? Yeah.
Horst,
Yeah.
why do you don't use a lateral view for deploying the left side disc? I'm not so familiar with the TE because in the kids without anesthesia and so on. So I always using the lateral view, and like you have seen it now for measurement, it's very
Well, sorry, I have too much noise on my ear. Jürgen, can you stop that? Okay, so repeat your question, please.
Why do you don't use the lateral view for deploying the left side?
Okay, we use LAO. So we use LAO. And we started with, I think it was 35 LAO, and now we are a little bit more LAO. Can't see it here.
Okay, Dietmar, why lateral?
Not lateral.
You have the best view if the left disc corrected position to the intra-atrial septum. I'm always using it in Ramallah or anywhere. By this position, we have no TE, and so you can use this lateral view in any cath lab without TE.
But are you talking about full lateral or LAO?
Full lateral, yes. Okay. Like here, this is nearly full lateral. This is 60 or 70 degree, maybe.
Yeah, that's
like
not full lateral.
Yep.
Lateral is 90.
Can we deploy the device?
Yeah.
You're not doing a tag?
No. I don't do a tag test unless I'm really in doubt, but the position looks very good, so I don't do a tag test.
Okay. All right. I think you've got the device in place. You've got 18 millimeter or thereabouts compression of the disc, slightly oversized, but release it.
Okay, so I unscrew the red thing here. And now it's released.
And that actually shows
and it did not embolize because of the proper size.
So can you replay that if you've acquired it, Horst?
Oh. Let me try. Yeah.
Okay, just watch the device, how it orients. So there is some angulation or change of angle, isn't there? So that means that the flexibility is not as optimum as we think it should be.
But it's much better than when you just have a screw there.
Yeah. Okay.
Good.
All right. Any other questions for Horst before we let him go?
Any thrombus?
Oh yeah. What's
yet.
the ACT now? Right, Horst and Stefan, well done. Thank you very much for that. We'll move away from you. Well done.
Thank you very much.